when I started on the ITUs again, I noticed just how phenomenally overweight patients were. And I've been quizzing the juniors who work with me and asking them, at what BMI do you kind of notice that a patient is obese? When does it start to play into your equation as you think, this patient's level of obesity is affecting their outcome? And what do you think it is? What do you think the BMI is that they start to notice it?
What do I think?
What do you?
Me personally, probably around 30 would be my guess. I don't know what it turned out.
The average from the juniors was 35 to 40. That's when they start to think about obesity. So when they write down the past medical history on the sort of handover sheets, they often don't include obesity unless it's morbid obesity. And when they write death certificates, they also don't think that obesity of BMI 30, 32, 35 is significant. People have got so used to obesity, they're not even registering it.
Wonderful. Well, hey, welcome. Thank you for taking the time to do this. I know this is, I think, what evening time where you are. I guess, assuming you're still in the UK, if I'm not mistaken, correct?
No, I actually live in Denmark, so I work in the UK. I moved beginning of lockdown. I thought this is getting a bit crazy, and just thought that what was going to happen, the city wasn't going to be a good thing. So we were weighing up whether we were going to stay in the UK or move to Denmark, and we just decided basically in Danish countryside.
Okay, well, regardless, it's still evening. You're still in. Well, interesting. I don't know enough about. I know there's been some stuff with Denmark going on as well, but and I was kind of giving a little background on you, but I'm sure I didn't. Obviously didn't do it completely. But can you just tell us a little about yourself? I know you're a physician in the UK. I believe you do anesthesia, if I'm not mistaken. But tell us about yourself a little bit, if you don't mind.
Yeah, sure. So where to start? Well, it's kind of standard medical training. Took a bit of time out to do some other things along the way. Helped set up a Buddhist meditation charity and taught Buddhism and meditation in lots of different countries for sort of 20 years, sort of sliced alongside a medical career. Did research on exercise testing. So I know a lot about sort of heart, lung, and neurology combination in an exercise setting. And I started an exercise intolerance clinic. So I look at people who've got unexplained breathlessness. So everybody who doesn't fit the typical pattern of a cardiologist or a respiratory physician, of which I think there's quite a few potentials out there. And then I was doing cardiac anesthesia, spending 10 years watching the result of lifestyle put itself onto the surgeon's table. And then COVID came along, and it was kind of because I also did cardiac intensive care. They asked if I could move into the sort of the general pool and take care of patients with COVID. So I started that, I think February, March 2020, and was looking after patients with COVID most of the time for the next 2 years.
Yeah, interesting. My ex-wife was a cardiac anesthetist. She did her fellowship. She had ended up doing a double board fellowship in pain and cardiac anesthesia. She's quite well academic in that stuff. But so I guess one of the things, and obviously you're doing Buddhist stuff and doing some of this other stuff, and you're seeing the outcomes of lifestyle, basically. I mean, most of, as an orthopedic surgeon, when I went in, I was like, well, I'm just going to fix broken bones, right? And that's not lifestyle. Well, it kind of is. I mean, trauma is kind of disease, but I'm not dealing with what the family practice guys are dealing with. But honestly, the longer I got into it, I was just like taking care of arthritic knees and tendonitis in the shoulder, and it was all lifestyle related stuff as I came to figure out anyway. So 80% of what I saw was lifestyle, and you kind of lost the sort of the glamour in that. But I guess we'll get into this now, because I mean, I don't know, I guess it was, maybe 6 months ago, you made the news pretty prominently in the UK as you were questioning, and I can't remember the name of this guy, Javid something. I think the health minister for the UK or something like that. You said, hey man, I have already had COVID. I'm immune. Why am I being forced to have a vaccine? and
That's
that
right.
made a lot of headlines. And he didn't have a I don't know if he had a good answer for it. But what was the impetus for that, and how did that turn out for you?
Yeah, so he came to visit the COVID ITU at my hospital, and first of all started out with a few sort of general questions about the patients and who was vaccinated, who wasn't, that sort of thing. And then he went on to talk to some of the nurses, and he sort of approached a group of the nurses who were all pretty senior, some of whom I knew didn't want to be vaccinated. And he said, "Look, what do you think about these new rules that are coming in for NHS staff?" And basically, we are looking at 100,000 members of our healthcare service in the UK. And if you want to times that by five, you'll get the sort of perspective of the number of healthcare workers for the US. Yeah, 100,000 members of staff being sacked if they didn't have a vaccine by the 1st of April, which was just a couple of days ago. And this was back on the 7th of January. So we had only a few weeks left in order to have your first sort of shot if you're going to follow the rules. And I'd already decided by then that I didn't like the way the things were being done. And I thought, well, I've got the possibility of working in healthcare in other ways. There's other plans I've got, which I'm putting into motion now for myself. And I thought, look, I'm prepared to say how I see it. And why not? I mean, when you just have, the most prominent voice of the thing you're opposed to directly in front of you asking that question, you've got to stand there and speak up. So I said I'm not happy with it. I've said I've got antibodies. I said the protection the vaccine was supposed to be giving on transmission was pretty darn weak. It was starting to reduce back to zero by about 3 months, and for people who were already immune, the vaccine was probably reducing back to the same level as someone who was. So if you've had COVID and then not had the vaccine, compared with someone who's not had COVID and had a vaccine, it doesn't take long until those two situations equate under anyone's rule book. And I just thought it was crazy that they were going to fire me. I took 25 years to train and get to this sort of stage, probably longer than that, almost 30 years of training for a vaccine that isn't going to stop my patients from getting COVID. I was anyway working on a unit at that point with patients only with COVID. It was just nuts.
What is his background, John? Is he an actual physician, or what was his
I think he
scientific?
was the vice president at JP Morgan, making him extremely well qualified to run a healthcare service, as you'll understand.
So he's basically an administrator. So he's about making money and bottom lines and stuff like that. And I guess, well, I mean, again, correct me if I'm wrong, but most of the healthcare in the UK is done via the NHS, which is, my assumption, is not a for-profit venture. It's basically the government-funded uh, uh, healthcare system. Do you find? I mean, one of the I guess things in the United States is, many of our healthcare systems are for profit, and I can tell you, working in that sector, it's very much about that. I think if it's not profitable, it's not done typically, or it's very difficult to get done. And I mean, it makes sense from a business standpoint. But do you see a general concern with healthcare in the UK?
Yeah, there's a very widespread concern about what's happening with the National Health Service. A lot of people are concerned that there's an attempt to kind of destabilize it and therefore put it forwards towards private care. But we've got loads of examples around the world where we can see that if it's not purely private, as in business orientated, private has an influence on public and politics. Yeah, and there's such an overlap. The politicians go to work in the big companies, the regulators go to work for the companies they used to regulate as pharmaceutical companies. There's so much sort of crossover of interests of people who are actually trying to make decisions, and I don't think that's a very good thing.
So tell me about why Denmark? What is Denmark? How is Denmark better, different? What prompted the decision to go there?
My partner's Danish. Her kids are Danish. Between us, we've got 7 boys who are between 10 and 21. And it's always been a bit of a juggle as to where to be. We had a few years in the UK. My boys are actually now living in Germany. And the Danish countryside just offered us the possibility to have a good sized house in the countryside where we were still close to a city and could still function in those ways. So I've got a 10-minute walk down to the beach. There's nobody there at all. It's just, good nature. The forest is nearby. There's an easygoing community, and we're an hour from Copenhagen.
That sounds very nice. Look, how is the healthcare? I mean, and it seems like different countries in Europe have had a different philosophy. Everybody talks about how Sweden said, let's just, let the nature take its course, so to speak. And other countries like New Zealand have this zero COVID policy where, and obviously New Zealand's not in Europe, but you see how we have different things. How is Denmark treating this? Are you still considered a pariah if you don't line up for shots, or how does that work there for the healthcare system?
So now it's settled down. There was a pretty strict system put into place, but it only really affected people who were in the cities. We basically got on with life. We moved to this community in the middle of lockdown, got to know loads of people, loads of contact. Sure, there's been some people who've been a bit cautious and a bit scared about things, but in general, it hasn't interfered with things. But the Danish government, about a month or so ago, admitted that they got things wrong with their COVID policy, which is pretty phenomenal for a government to actually stand there and admit it. And they then said that COVID is no longer a socially significant disease. So they took it out of the category where they can make special rules about it.
Now, early on in this COVID pandemic, Boris Johnson was hospitalized. Clearly his overall health status did not do him any favors, and he sort of, for a brief period of time, started championing the concept that, hey, maybe we need to get healthier, but that was, I think, fairly short lived. Do we see any more of that? I know in the UK it was conspicuously absent. Our COVID response, no one mentioned, at least in a major way, at least from the government side, no one said anything about, hey, this would be a good time to maybe lose some of the pounds, stop eating the junk food, get some exercise. That was never mentioned at all. How was that treated in the UK? Overall, did you get much discussion around that?
There was nothing on that. Most of the measures of lockdown, of course, drove people towards pretty unhealthy habits as far as their sort of glucose control was concerned. Boris Johnson initially said, got to lose some weight. But then last Christmas time, he just said, don't bother trying to lose weight, just get a jab, it's easier. And that kind of transition of, I need to make a difference. And then, I couldn't make it myself, so you shouldn't bother either. I think it's been pretty widespread. When I got started on the ITUs again, I noticed just how phenomenally overweight patients were. And I've been quizzing the juniors who work with me and asking them, at what BMI do you kind of notice that a patient is obese? When does it start to play into your equation as you think, this patient's level of obesity is affecting their outcome? And what do you think it is? What do you think the BMI is that they start to notice it?
Or what do I think?
What do you?
Me personally, probably around 30 would be my guess. I don't know what it turned out.
The average from the juniors was 35 to 40. That's when they start to think about obesity. So when they write down the past medical history on the sort of handover sheets, they often don't include obesity unless it's morbid obesity. And when they write death certificates, they also don't think that obesity of BMI 30, 32, 35 is significant. People have got so used to obesity, they're not even registering it.
Yeah, it's kids growing up today, they are going to be so used to obesity that it becomes normalized. And I can, in the United States, I think right now we have 45% of our population is considered obese, so BMI above 30, and then there's a huge number that are morbidly obese, a significant percentage, and then just being overweight is common. And I know people push back on BMI as a metric, but for 90% of the people, it's accurate. There's the outliers like myself, like my BMI is about 29. I'm not obese, so obviously, I'm not overweight. I'm lean, but because I carry a decent amount of muscle mass. But it's very clear that for most people, we see that as a huge problem. How, we heard stats in the United States, something like, I think something like 80% of the people that were hospitalized or had or died were suffering with obesity and all the other outcome sort of comorbid factors. I assume that was consistent in the UK. What were you? I mean, you were a frontline anesthetist, cardiac anesthetist, tubing people in the ICU or ITU, whatever you guys call it there. But what did you see? What was it? What, were you seeing all these lean athletes that were getting sick, or what were you seeing?
I never saw anyone healthy. I never saw anyone without comorbid disease. Not a single person on the ITU. And I asked my colleagues, and no one else ever saw one. We saw one guy who was a personal trainer, and I was kind of shocked when I first saw him. I thought, oh, wow, okay, so it can affect someone who's in good condition. And then it turned out that he'd smoked for 30 years. He had emphysema on his lungs from that. He'd quit about 5 years ago, but he'd smoked for quite a while. And he'd had a leg bone infection the year before and had MRSA and been hospitalized for about 8 weeks and had long courses of antibiotics. So his immune system was probably pretty challenged by that as well. He was the closest person to someone without a significant past medical history who we saw. And that's the busiest intensive care unit in the UK pretty much for COVID.
Interesting. And I would see occasionally there would be younger people hospitalized, and they would say, and they would literally have a picture of the person who'd be like a 22-year-old. And I said, this young person got sick that was healthy. In the photo, they were morbidly obese. And I was like, well, yeah. that sort of says a lot right there. But what, as far as the response there, one of the criticisms in the United States was, you were treated two ways. One, if you were not acutely hypoxic, they were just said, stay home until you become hypoxic and then come to the ER. And then it was, intubate everybody, or initially they were intubating everybody. That caused a lot of problems. But was it similar in the UK where they did, if you were sick, did they just say stay home? And
yeah, it was definitely a stay-at-home policy, which was pretty strange. Why we weren't trying to look for early intervention therapies much earlier on. The idea that you had to be desperate to come in was a pretty poor state. We know that the longer you've struggled beforehand, the less likely you are to do well if you get intubated. So I know there's been lots of sort of stories about, how ventilators kill people, but, most people who die are next to a doctor. It doesn't mean doctors kill you. Poor outcomes are associated with all kinds of things because that's what you throw at people who are dying. Yeah.
Yeah, sure. I mean, if you're getting intubated, things aren't looking good and they're not in your favor. Like simply if you code, the odds are you coming back are not very high. I mean, it's just what it is at that
about
point.
60-40 for patients we intubated. So 60% survived.
Okay. Well, that's better than 10% or so. So that's good to hear. Has there I think a lot of people, even the people that were very pro lockdown and all these sort of aggressive measures, have sort of revisited that, and many people have come to change their mind. What is the overall opinion in the medical community? Because we only hear, it seems like we only hear from a few people that have a particular opinion or a particular narrative that they believe in. I saw data on like surveys on physicians, done, physician surveys saying, what are your thoughts on the CDC? And there was a tremendous amount of mistrust. It's like, did their credibility go up or down? And almost everyone said their credibility went down. Among your colleagues, was anybody talking like even under their breath or behind the scenes saying, hey, this doesn't make sense?
Very few. The idea that 10% of your colleagues are going to get sacked for something that is scientifically not really that robust and isn't really going to have much of an impact on your patient population. For me, that was shocking that there wasn't a large outcry. The timing was a little bit awkward because people were worried whether Omicron was suddenly going to put us back into a sort of crisis mode again. So people didn't really want to make a big fuss before Christmas time, and they weren't sure what was going on. But it was a clearly inappropriate idea to sack 100,000 members of staff on the basis of the data they had at that point. And very few of my colleagues have said, we don't think this is going well. And the main problem, the main reason why they don't like to go against it is they saw a difference from the timing of the introduction of the vaccine and the reduction of patients presenting to intensive care and dying of COVID. And they just don't want to put anybody off. They know that a lot of people from certain marginalized or communities or minority communities have been less keen to take it up, have been the people who have been most likely to have a problem with COVID-19. And they felt that any kind of talking negatively or even the wish for nuance in the conversation was going to put people off. But I think that, like you said, with the views on the CDC, what's happened is mistrust has grown in those who are supposed to deliver information. Because once you find out that information wasn't a good picture, that it didn't do you good, that it might have been influenced by other factors, you're much less likely to trust that information in the future.
Do you think, assuming that somewhere down the road, 5 years, 10 years from now, we'll have something similar, we'll have another, infectious disease outbreak. Do you think there'll be a different response this time, or do you think they'll have any sort of lessons learned from this?
Yeah, I'm not sure that those who are trying to deliver the service are going to be behaving very differently. But I think there's a much more active and vocal community of people in society now who are well aware that you can't just let the government keep saying and just this and just that, and it's just 2 more weeks and just this and just that, because that's how it started with this sort of nudge behavioral psychology science to sort of slowly nibble away at what people valued and how they felt, creating fear in society, because it was actively done in that way in order that people would accept things. But now there's a much larger group of people who are aware of that sort of process and are quick to stand up and say no.
Yeah, one of the things as a surgeon, I would consent people for surgery, and I would explain to them our options, what I think reasonable complications are, and they always had the choice. Even if I disagree with their choice, I still respected their choice. I mean, it's like I remember at one time I had a guy whose leg was so infected, he was overwhelmingly becoming sick and septic, and it was like, we have to take your leg off. And they didn't want it done, and they refused and actually left AMA. And I was like, well, that person's he was still mentally competent, and so he could make that decision. But it seems like around some of the vaccinations, when you are coerced by threat of losing your job, you don't know if you're going to be able to feed your family or stay in your home. It seems like that violates the tenets of informed consent. Is that fair to say in your mind?
I think that's very fair to say. And, we've spent decades practicing informed consent. And that's not just me and you, that's all of our colleagues. We're all been acting that way. So this is very strange that suddenly we could tell people who essentially weren't at risk of having the disease significantly themselves, but they should just take this vaccine. And we didn't really know about the outcomes, but it was probably good if they did. So there was a very poor sort of risk-benefit analysis that could have been presented. That's probably why we didn't go through the process of informed consent, because the data just wasn't there. But the key thing that was interesting with the vaccine was that there was this argument that it's not about you taking it for you, it's about you taking it for someone else's benefit. Now, we don't have a history in society of you having to have a medical intervention to benefit other people. Yeah, it's very strange territory.
Yeah, the other thing that was very unusual was the fact that the sort of the assumption was a previous infection would not confer immunity. Prior to this, anytime, you've had an infection, measles, mumps, chickenpox, the seasonal flu, you would say, okay, I'm covered. And that was it. And there are a few exceptions to that. There are a couple infectious diseases where it necessarily doesn't work, and I can't remember which ones they are, but it's by and large, the majority of diseases, the assumption should be once you've had it, you're well protected. I mean, there were, as you know, there were literally 100 plus studies showing the robustness and the efficacy of natural immunity, even with COVID-19. And I think there was one study out of Kentucky with small numbers where it was questionable, and that was the only thing they leaned upon. What was the reason to defer and make the assumption that being infected was not going to provide protection?
Um, I think there was a very singular view that the vaccine was the way out, and the way to make that the way out was just to tell everybody, just get on, take the vaccine, and stop asking questions. It was a big shift away from the kind of direction of medicine in the last 20 years of patient-centered choice, and moving back towards paternalism, really, and just saying, look, you just got to take this. And you have to feel that there was a desire to vaccinate that was unusual, yeah. And whether that was really purely vested interests, or it was a feeling that it was a good way to control society, that they could get everybody onto some kind of vaccine passport, and from there jump towards social ID. There's so many possibilities, but they were clearly ignoring the history of immunology.
Yeah, that was something that I had, I was just scratching my head, about a lot of these things, and I know a lot of people, when it came to, particularly in the beginning, when they said, well, wear a mask made out of your t-shirt over your face, I thought that was a little ludicrous. And as a surgeon, I didn't mind. I mean, I wore a mask every day in my career, as you do. I mean, every time you go to the OR, you're wearing a mask. But when you look at the data on like surgical site infections and masks, the data is equivocal. It just doesn't really seem to show a big difference. Now we wear it. Now I would wear it because I would often get splashed in the face with blood and other fluids. Right, splash guards on your face. And that was primarily, I think, the reason that I wasn't worried about transmitting a viral infection to my patients wearing a surgical mask. And that was, again, another thing that, people outside walking around, it just didn't make sense to me. And I kept getting this, why do surgeons wear masks? Well, the reason is really this. But anyway, we had that sort of stuff going on there. Let me just ask, I wanted to ask, because there's a couple other things that you mentioned. So you said you did some time studying Buddhist, I guess it was meditational practices, and what did that teach you, I guess?
I suppose that if you use some sort of method like this, yeah, you are looking to balance something in yourself, yeah. There's lots of ways to go out there and look for that balance. But I think that Buddhist meditation for me had given me the ability to look into some situations and see what was going on in the situation and what was going on for myself in that situation. And that's very handy if you can separate that out, whichever way you get to that scenario. I think that I was also, what was effective about what I did was I didn't get angry with the health minister. If I'd been angry and showed that in a sort of typical, expressing yourself, shouting, calling him an idiot or whatever else, yeah, then it probably wouldn't have got on the news. Probably the trust would have asked for it not to go on or something like this, in my hospital. Or if I had, I would have just been dismissed as a crazy. Yeah. But the fact that I'm a consultant doing COVID ITU, that I've got a good educational background, that I specialize in heart and lung function, and I spoke very calmly. And when he asked, when he came back with, that's just your opinion and things like this, I just furthered the conversation with him and just kept going. So I do think that my sort of meditation practice and the other things I've done over the years did something for me. And the other thing I think is that in the last months, I've been doing quite a lot of other sort of intense personal work. And I felt that it's probably time to kind of realign myself with where I am. Because when you check in with yourself more, you start to see whether you're outside the world you're in is fitting. And if you start to see, hey, this isn't the right place for me, or things have changed inside of me, sometimes it will just go smoothly, and sometimes there'll be a jolt. And sometimes you'll see that things will suddenly change from a certain event. And that was certainly true for me. I mean, I can feel that my relationship to my colleagues has become a bit more strained, but I came in contact with hundreds of thousands of other people in the UK who were very much behind me. I had hundreds of personal letters written into the hospital with thanks, flowers, gifts, this sort of thing. Yeah, this is normally what a doctor never receives, at least not an anesthesiologist, in their entire career. Yeah. And I went from, I think I had 250 Instagram followers that morning, and I had 10,000 in the evening and 60,000 2 weeks later. I did, a bunch of press on the TV and wrote articles in magazines and newspapers. And suddenly I have a world of new people in my life who are more interested in speaking out, more interested in questioning what we're doing. And that's great. That's great for me.
Yeah, that's something that you bring up the point, because I would do surgery, and often patients would, here they bring me a card or some kind of food as a thank you. But the anesthesiologist, no one even knows it exists, right? They're just kind of in the background. Who's that guy?
You know you were there.
Yeah, you don't remember them. But because as a cardiac anesthesiologist, I mean, you're taking care of a lot of people with heart disease, obviously, off pump, bypass, on pump, valve replacements and things like that. What are you seeing? I mean, because I'm on as I'm on a meat-based diet. I had my heart scan. It was perfectly clear as far as calcification goes. But the sort of belief is, uh, I'm going to die of heart disease because I eat a lot of saturated fat and meat. Are you seeing any commentary? I know, like Phil Ovedi is a cardiac surgeon who's in part of this community. He says he sees people. I mean, most of the time they have quote unquote normal or lower cholesterol, or much of the time, and it doesn't seem to be. What is the characteristic of the people that are rolling into the OR? Are they diabetic? Are they obese? Who's coming in for these heart procedures?
Yeah, so I mean, smoking's still the biggest factor driving presentation, because most people who present are in their sort of 60s, 70s, and a fair few in their 80s, I would say. Hypertension still a big problem, and type 2 diabetes. The level of obesity we've got in the UK is not as significant, I think, as it is you've got in the US. It's part of it, but not the driving factor.
Yeah, that's in those factors you mentioned, like there was a recent analysis of the women's health data and looking at, heart disease, and it was type 2 diabetes by far and away was extremely highly correlated with heart disease. And then it was smoking, like as you mentioned, obesity, hypertension, metabolic syndrome. And then the LDL cholesterol was relatively a minor. I mean, it was a factor, but it was relatively minor. And so we have this you don't do a lot of preventive primary care, but you see the effects of this stuff. And we have this sort of laser myopic focus on, let's get everybody's LDL cholesterol as low as possible through diet and drugs. And we tend to not focus as much on the other thing when it comes to heart disease. Do you, again, you probably get to see people right before they go to sleep, and they don't remember you when they're waking up, because they're still having the after effects of anesthetic. Do you get to interact, I guess, through Instagram now, or social media? Are you finding that are you finding a role in education? Are you engaging in any of that stuff?
Yeah, so I ran a service at the hospital called this exercise intolerance clinic. So I was looking at all causes of fatigue and breathlessness. So I'm becoming I had a very much a sort of health education role with these people. An awful lot of patients would turn up. I'd look through their diet, I'd look through their sleep, I'd look through their exercise and their stresses. A lot of people were on a very low protein diet, had no idea, no one had ever gone through that with them before. A lot of people have got poor sleep, they're presenting tired and breathless, and no one's asked them how they're sleeping. A lot of patients' symptoms were triggered by social factors, life events that happened a few years ago that led to suppressed emotions, that led to changes in their lifestyle as they sort of sought coping behaviors with alcohol and eating, and their weight went up and pain increased and mobility went down. So I've been involved with that for quite a while. And so, now I see there's an opportunity. I've looked at people like yourself and seen the sort of online health community concept. So I'm going to set up, I'm in process now of setting up a community called Health Awakening. And that's going to sort of focus around three things. One is that you've got to rely upon yourself rather than big government or big pharma or big food. You've got to understand there's a power in community, and that we used to be always much closer in community than we are often these days. And people need to get feedback. They need to get support and encouragement when they're going to make change. And then thirdly, that essentially we've evolved to where we were about 200 years ago. And by that, I mean both genetic and cultural adaptations. And what we've done in the last 200 years with modern society is a huge shift away from that. And we're no longer optimized for the environment we're in. And there's no way that we can catch up. So we've got to look at where we're away from our health with modern society, look at that sort of ancestral health paradigm and apply that.
Yeah, I'm glad to hear you doing that. I'm sure you'll make an impact. I know I've been very fortunate. I've been able to make an impact on a lot of people's lives, and it's extremely rewarding. I mean, I wake up with a smile every day because I get to, I get to do this. And as a surgeon, I mean, I would help you replace somebody's knee and they would feel better, but it's not the same magnitude of effect, and it's not the same sort of thing that you're doing, particularly when you're preventing this sort of stuff. When it comes to, like you said, exercise intolerance, what are the things that are leading to that from what you can tell?
So I see a lot of patients with autonomic nervous system dysfunction, so breathing pattern disorders, increased resting heart rates. A lot of patients who've got a sort of what's called a postural orthostatic tachycardia syndrome, POTS. So they stand up and their heart rate's like 120, 130, and they look otherwise healthy and well. So their autonomic nervous system has gone a bit haywire. Their respiratory rate's often very high, so they're hyperventilating without really realizing it. They've driven down their carbon dioxide and they're feeling a bit dizzy and fatigued, and they get odd neural symptoms because of the low carbon dioxide. So that's another pattern. I've seen a lot of patients with chronic fatigue syndrome. Found a way to actually sort of demonstrate that on an exercise bike. So you can demonstrate that it's not a question of oxygen delivery, it's a question of oxygen utilization. So it's it's another metabolic disease. They do pretty well on a keto diet, and you need to sort of graduate them. So I see a lot of people where essentially they need that health education. They need to understand that it's more than just one thing. It's not going to be solved by any pill. And they've got to sort of peel things back and understand that wider process. So I do everything from teaching breath work to I'm just doing a psychotherapy training at the moment, and I can look at their LDL, and so I can take a very broad view on people's health.
There's in the United States, it's thought that many people average weight gain post-pandemic was something like 12, 14 kilograms, fit 30 pounds or something like that. Just enormous. That didn't do anyone any favors. And we're seeing higher rates of cardiovascular disease. And some people will say it's due to the stress, it's due to weight gain. Some people will say, some people out there say it's vaccine related. Are you seeing an increase in this stuff now, like a backlash or a catching up of disease and heart disease post-pandemic, or as we're winding down from this stuff?
So I've stopped doing cardiac anesthesia. I'm just doing intensive care now. So I'm not seeing that presentation rate. But, as an anesthesiologist doing cardiac surgery, you see 2 patients a day. You don't operate usually, almost never on more than 2 patients a day. You do one in the morning, you do one in the afternoon, and then you come back, 2 days later and you do another one in the morning, another one in the afternoon. So you're not looking at that waiting list. You're not looking at the presentations. What's been scary is the number of friends who've had heart issues over the last couple of years. In particular, people who I think have had a vaccine-related cardiac issue. Really young, healthy people, and all these stories of athletes having their issues. So there's going to be many, many causes. I think COVID is probably causing more problems in the otherwise well people than we recognize. And I think the vaccine is also causing more problems in otherwise well people than we've recognized. So it's pretty hard to pull the data apart.
Yeah, I guess there was a recent U.S. tennis tournament where I think 15 of the athletes could not continue the tournament for whatever reason, fatigue or heart issues, or it's interesting. That's not normal to see young athletes in their 20s and 30s having withdrawal from tournament because of health reasons. It just doesn't happen that often. So it's kind of interesting to see that. I wonder, if we're going to critically look at that stuff and if there's going to be any kind of, analysis of what's going on down the road. I know we're still waiting on like some of the safety and efficacy trials to be finished on the vaccines officially. They were EUA, emergency youth authorization. They haven't finished their trials, and so we'll have to see how that plays out. Do you were there anything that you think that during the pandemic that you would have done differently if someone had made you in charge, if you had Java's job and you were in charge of UK health minister, how would you have handled it?
I would have gone straight for the health drive at the beginning. So first of all, I would have, in the UK, I would have locked down briefly, shortly, early on, and said to people, this is going to be very tough, but I'm more concerned about the effects of the lockdown on the whole of society, on our economy, and on the health of people, especially the kids. Locking them up in their homes is a terrible thing to do for those people. And those who have got a lower level of income probably suffered the most as well, and they're the ones who've got the most health issues in the first place. Then I would have really gone for a drive on changing health. I mean, I think we should have been, rather than telling people to stay at home, we should have been telling people to be out twice a day, exercising as a minimum. Yeah, we should have been creating outdoor gyms. We should have been turning facilities into sports venues. We should have been supplementing the entire fitness industry, stopping tax, for example, on the fitness industry for 2 years and watching the drive, because the gains that could have been there would have stayed as well. You wouldn't have just had those gains for 2 years. You could have made a shift in the cultures and the health of society.
Yeah, one of the things, and I often hear this sort of counter argument is that, we always tell people to lose weight and they never do. But I look at, like again, in the United States, when we look at our smoking, our campaign to reduce smoking, we went from 45% of the population smoking cigarettes in 1954 to where it is today at about 14%. So we've reduced that, almost threefold, and that was done through a coordinated government and industry effort. And if we were to say the same thing regarding exercise, losing weight, junk, reduction in ultra processed junk food, I think that's a message that we could certainly do. I don't know why we don't do that as a society. I mean, to me, you can fight about carnivore diet, vegan diet, Mediterranean diet, whatever, but what's commonly clear is people are eating too much of this ultra processed garbage, and I can only think it's a conflict of interest. I don't know what your thoughts are on that.
Well, I think there's a question of the singularity of cigarette smoking versus the complexity of obesity. So it's very clear there's one thing you need to do to stop the harmful effects of smoking, and that's stop smoking. Whereas what do you need to do to treat obesity? Well, actually, there's so many things you need to shift in society. And that means that when you've got those vested interests, everyone can play one thing off against another. So Coca-Cola can sponsor some studies that show that you can drink Coca-Cola and not gain weight. And then they can say, look, see, it just needs to be part of a calorie controlled approach. It's not Coca-Cola that's bad. So, we know that there are almost no food products out there that in themselves make you obese, because no one is taking that single product to such an extreme. Yeah. So there needs to be a stronger regulation on that, and a much more a drive towards incentivizing health.
Yeah, I agree. Well, I mean, I would say I take one product to extreme. I eat beef every day, every meal. I've been doing so for years, and I can say fairly confidently, at least in my situation, many others, it doesn't seem to lead to obesity. Now, if I were to eat 100% Coca-Cola diet, well, I would die. I mean, I wouldn't get any essential nutrition from that. But I mean, I think there's other foods that we could do. Certainly, we see the results of eating, you know, chips and fast food every day. That doesn't seem to do well. What is your personal dietary? I mean, do you have any dietary preferences, or how do you typically do that?
So I've moved through quite a few things. I've done carnivore for a few weeks to see how that was. I've done keto for quite a while. I tend to be fairly low carb. I don't eat much processed foods at all. Extremely fortunate. My lady is a chef, and everything's just kind of cooked from good, fresh ingredients. It would be pretty hard to really stop eating all the good food she produces. And I don't really have many health concerns myself, so I've got a little bit of leeway there. Gluten's the thing that I have to pay attention to. If I start eating the sourdough each time it appears in the kitchen, then I know my joints are going to start aching when I wake up in the morning, and I'll get dry skin, and my scalp will look like there's been a snowstorm. So I can see what affects me in that sense. I definitely feel better on a pretty high protein diet. We were away for a week on a retreat last week in the Netherlands, and it was a mainly vegetarian diet at this place. I made a few kind of have a bit of extra proteins, and there was some eggs and fish and a few other things. But as soon as that week was over, myself, my wife, and a friend went back into Amsterdam, and we all said steak. Yeah. So the first thing we did when we got out of that place was to readdress the balance.
Yeah, and we, as you're probably aware, there is a global push to get us to eat less protein, or to eat, maybe eat our protein sources from beans and things like that, which I think that's an inferior source of protein. I mean, I think the evidence is pretty clear on that. Do you have any concerns about, like you said, you have seven children, seven boys. I've got four. Do you have concerns about how they're gonna navigate health and society over the coming next generation or two?
Well, those boys have all got a pretty healthy desire to eat meat. I would say they've grown up in a culture where we've explained, the nature of meat, uh, as well as the reputation it's got and the actual, benefits for them. But I do worry about that. A number of friends' daughters have had anorexia, and you can see the pressure from social media, particularly on the girls. There's this general concept, which you'd be very aware of, that a vegan diet is a healthy diet, and it's just not true. I mean, you can see the evidence when patients turn up at clinic. I see a far higher percentage of vegetarians and vegans than I should do, according to statistics. Very few of the patients I see are eating enough protein. If you're going to do a vegan or vegetarian diet, you've got to be really careful. You've got to know what you're doing if you actually want to reach basic targets. I think the Ayurveda system has got some ways of getting people onto enough mung beans and various other pulses that they can achieve those targets. But there's very few people who are vegan and vegetarian who are really meeting those targets.
Yeah, it's interesting you said it. So, as a cardiac anesthetist, seeing people being treated for heart disease, you see a disproportionately high number of
No, so
vegetarian.
in the exercise intolerance clinic,
Oh, exercise intolerance. Okay. Okay.
fatigue and breathlessness, not from the honest. I don't have enough time with those patients to go through their history. It's already too late.
I see.
That's one of the reasons I went into cardiac anesthesia. Is by the time you get there, there's no point in looking at prevention. You can look at management afterwards, but when you need your coronaries replaced or your valve replaced, it's usually too late to start to make those changes. You can make them elsewhere, but you can be pretty we can be pretty secure. It's like with orthopedic surgery, if your bone is broken, yeah, an orthopedic surgeon is probably the best person to see.
Yeah, sure, of course. Yeah, you fix the bone, and then and the nice thing, and as much as I sort of talk down upon a lot of the healthcare systems and in their, I think, ineffectiveness against prevention and handling chronic disease, we do a very good job with acute care. And I think, like I said, if I crash my car and my femur sticking out, please don't give me ribeye steaks. Take me, take me to the hospital so somebody can rod my femur or something like that.
Yeah.
For the same thing, if you're having an active MI, you're gonna want to be treated that way.
We're a acute sick care system, basically. We're not a chronic sick care system. We're not a health system. We're an acute sick system.
Did you just back to the initial thing with the health minister? Has he changed his mind, or have they changed their policy with that? And do you think part of what you did had some influence on that?
Well, yes, they have. They've pulled back the mandate. It took a little bit of time. They said there's going to be some consultation process. There's a very high 90% of the respondents on the consultation said they didn't think the mandate was a good idea. I'm pretty sure that some of the people I'm in contact with have been sort of, driving that support there. I've been involved with an organization called Together Declaration that has been campaigning against the mandate and various sort of vaccine-related restrictions and COVID restrictions. So once I sort of came into the limelight, I sort of lined up with various other people who were working on this, and we worked on it obviously a lot longer than I had. But my conversation with the health minister was the first one that hit mainstream media, and was the first one that was therefore passed around and showed another opinion. And that led to me being on TV and that whole conversation being raised. So, you never know. You never really want to say it was me who made the difference, but it seems that the timing was quite fortunate, and that the changes have happened now.
Well, I mean, regardless, I'm glad you were able to speak out and get the attention, because I think it was, like I said, I think it was very one-sided, and it did lack nuance for sure. And there was a lot of very intelligent people whose careers were really almost or effectively ruined by this, just because they had the sort of, the inquisitiveness to say, wait a minute, maybe we need to slow down and think about things. And this doesn't make sense. And that was not allowed for this. And there was obviously, this is something I just saw, that Elon Musk is now the majority shareholder. I mean, he has the largest stake in Twitter, and he has very much been a pro free speech guy. And so maybe that, because I was kicked off Twitter for 6 months. I was permanently banned for, I think, complete nonsense. But somehow they put me back on there. I'm not sure how that worked out. But are you optimistic or pessimistic? I mean, because obviously the censorship does not, we're told to follow the science, but then we're not allowed to talk about science, and that's very unscientific. Are you concerned about ongoing censorship? Do you think we're going to see a reversal of that?
Yeah, I'm concerned about it. I don't think that things are going to get better before they're going to get worse. I think we've got 10, 20 years ahead of us of small groups, essentially elites, trying to get away with more control. They've essentially achieved more control over the last couple of years, and I think that the majority of the population is not awake to that issue. We're still in a minority. The people you and I are hanging out with are not the average person in the community we live in. So I think it's going to get worse. I suspect 10, 15 years of more trouble, until it comes to the point where more and more people have realized that they've lost a lot and not gained anything.
I recently saw a stat that the number of democratic countries versus autocratic societies has shifted dramatically in this. There's less democracy and more autocracy, and I think that's a troubling trend. We've almost gone through an hour. I unfortunately have to go to a meeting. Steve, it was wonderful talking to you. Let people know where they can go to find out about your community. You've got a website, just how to get a hold of your social media, so on and so forth.
Sure. So Instagram Dr. Steve James, so Dr. Steve James. You'll see a picture of me and a couple of kids behind me, and you'll probably recognize the posts. And then coming up, and I mean, if you Google Dr. Steve James, I've got a website, drstevejames.com, and then the health community is going to be healthawakening.com, health-awakening.com, and that's going to be launching in the next couple of weeks. And that's not focused around a particular aspect of health, but about taking control of our health.
All right. Well, I just found your Instagram, just followed you. So anyway, I'm looking forward to seeing more stuff. Thank you very much. Have a great evening. Enjoy your time in Denmark, and I look to hear down the road how things are going. So that would be great.
If you're ever in Europe, Shawn, let me know.
Will do. Thanks. Okay. Bye bye, everybody. We'll see everybody tomorrow.
Thanks, everyone.
Bye bye.